Bismillah ar-Rahman ar-Rahim. I start with the name of Allah, the Lord of Mercy, the Giver of Mercy. I'm Dr. Muhammad Yusuf Hawan, and I'm a consultant physician. Today, I'll be talking about epilepsy. This discussion will not be about the pathogenesis, the manifestation, the treatment, but I'll be more focused on the awareness of epilepsy amongst the doctor and in the general population. I must confess that I have taken this idea from one of the famous Dr. Jacqueline French. He's a big name in epilepsy, has been the president of International League on Epilepsy. So her lectures are available on the YouTube. So I'm sorry I couldn't contact her to get the permission for that, but some of the slides, especially about the statistics, I've taken from her lecture. So what all I'll be talking about today will be the types of epilepsy, representative cases, a few cases I just present to make you understand that how the different types of epilepsy can present, how aware we are. So are we doctors, are we really aware of all types of epilepsy? Are we making the diagnosis at the correct time and the correct way? Or is there any delay in the diagnosis? And if there is a delay, how long is the delay in the diagnosis and the treatment? And what are the real life problems in getting to a doctor and making the diagnosis of epilepsy? And lastly, how can we improve the situation? So I'll start with my own patient, 66 years old lady. She was admitted with aspiration pneumonia, and she was diagnosed. Her diagnosis considered to have frontal lobe dementia about 4 years back because of her worsening communication and mobility. She was seen by the neurologist about a year back, and extensive investigation was done. The differential diagnosis was about the frontal lobe dementia, motor neuron disease, syngopalpia, autoimmune encephalitis, but none of the investigations were very convincing for any particular diagnosis. So she was asked for the follow-up, and the last follow-up, unfortunately, was about a year back. During her investigation, MRI brain, MRI neck were done, and there's some element of cervical radiculopathy, but this could not explain all the signs and symptoms. Nerve conduction studies, EMG didn't reveal any evidence of lower motor neuron dysfunction, and autoimmune serology was negative. During this admission, her oral intake remained poor. Concern was about swallowing. Husband had been helping her in feeding when more alert. Examination during morning ward round one day when we went for the ward round. So when we saw her, she was clenching her mouth, resisting movements of the arm, and was not communicative. The rest of the clinical examination was the heart was normal to auscultation, chest was clear. No other focal neurological sign was found, but she was drowsy, she was not responsive, she was clenching the mouth, she was resisting movement, and she was not communicating. So we requested for the SALT assessment after the unresponsive episode, but when the SALT team came to assess her, patient was alert and they were not concerned about any swallowing issue. So differential diagnosis for this lady was advanced liver dementia, epilepsy, and some form of the catatonia. So the concern was that because the reversible features, and sometimes she was more alert and was taking food orally, and the husband was helping her in feeding and taking medication. And then we had similar episodes which are not very typical of any form of epilepsy. So still, we thought, is it epilepsy? So three types of epilepsy I'll discuss in the later part of my discussion, we considered in this particular patient, there was non-convulsive seizure, temporal epilepsy, and the myoclonic epilepsy, but yes, that is about not about the young, she was quite old, but we thought about the myoclonic epilepsy. After we investigated this lady, and because she has already had very exhaustive investigation, we discussed with the husband, and we started with one of the treatment for epilepsy, the levetrestam, and she really showed a dramatic improvement with that. She never had any unawareness episode. She started taking orally, taking her medication regularly, taking her feed regularly, and she was discharged from the hospital in a stable condition. So this topic, awareness about the unawareness, I took it from one of the lectures from Dr. French, Jacqueline French. That is, are we really aware about all form of epilepsy? So what happens, in fact, whenever we think of epilepsy, the immediate picture that comes to our mind is a person with suddenly falls down on the floor with up-rolling eyes, jerky movements of the hand and the arms and the legs, and incontinence urine, incontinence stool, sometimes tongue bite. And this is horrible scene to watch. And then after a couple of minutes, the patient relaxed but confused, and after a few minutes might walk away. But this is what is the usual presentation about just one form of epilepsy, and that is the generalized tonic-clonic seizure. So there are so many other types of epilepsy I'll be discussing in later part of my presentation. Yeah. So the type of epilepsy could be the generalized, the description I've already presented. That is only one form of epilepsy, one form of generalized epilepsy, the tonic-clonic, and then the other forms, atonic seizure, absence seizures, and the myoclonic seizure. But then the more common type of epilepsy is the focal type of epilepsy. That is one part of the brain is involved, and then it might remain confined to that particular part of the brain or spread to other parts of the brain, and can lead to generalized epilepsy, starting as a focal but spreading to become the generalized epilepsy. So what happens in seizure in the normal brain, that all the neurons in the brain, the nerve cells, they are talking to each other, but they are talking to each other in a very civilized way. When some of the neurons are talking to some other neurons, the rest of they're not disturbed, they're not interrupted by other neurons. But when most of the neurons in one particular part of the brain start talking together, then that will result in excessive stimulation of that part of the nerves, that part of the brain, and will result in a seizure. So if those excessive conversation between the neurons remain confined to one part of the brain, that will result in a focal seizure. But if it spreads to the entire brain, that will result in a generalized seizure. But the generalized seizure sometimes can start with all parts of the brain simultaneously and begin as a generalized seizure. But sometimes the focal seizure start with a focal seizure and then can spread to the other parts of the brain and can result in generalized seizure. And I mentioned the focal epilepsy, generalized, and the focal and generalized, and then some different types of epilepsy. So the Dravet syndrome, the congenital forms of the epilepsy are usually presenting in the infants and children. So I'm not going into the details of all these things. Just briefly, the 10% of the population, that means 1 in every 10% will experience one isolated seizure in their lifetime. But as such, by definition, epilepsy is that when there are 2 or more seizures, this is epilepsy. There could be the focal epilepsy, that focal generalized epilepsy, and the problem is that this problem, epilepsy is quite common. It's almost fourth in the list after migraine, stroke, and Alzheimer's in neurological problems. But focal epilepsy is more common, and sometimes the patient presented with this funny turn, deja vu. They just feel that they have been on some strange place, but they found that they are familiar to the place, and some lips making. The most of the patients are really not aware of these symptoms, and usually they don't consult their doctors for the treatment or for the diagnosis or the treatment. And the result is that there is called sudden unexplained death in epilepsy. This can happen in 8 to 17% of the people with epilepsy. So the just sudden death, a patient have been diagnosed or undiagnosed with epilepsy, they can this could be fatal in 8 to 17% of patients. They can result in the bodily injury. They can present with the status epilepticus, that is the persistent seizures without recovering from anesthesia, and this is a medical emergency and can result to the brain damage, to the bodily injury, and sometimes very serious neurological consequences. Neurophysiological and psychiatric impairment, depression, reduced quality of life, and social disability. And I present a number of a few cases in my subsequent slides. You'll become aware that how disabling that these seizures could be, especially for the social setup. So I've just present few cases. These two cases, the first one I've taken from one of the lectures from Dr. Jacqueline French, that the bride and the mother-in-law. So the son brings his would-be wife to his mother and tells him that I'm going to get married with this girl, and the boy's mother tells her daughter-in-law, to be daughter-in-law, that congratulations, but I'll not be able to attend your marriage. So that if the mother-in-law refuses to attend the marriage of son and the daughter-in-law, it could be meaning probably either doesn't like her or there are some other issues. And subsequently, when they met the boy's father, he told her that there's been a problem, there's some social issue. She hasn't been out of her house for almost 25 years, and she was later diagnosed with epilepsy. So this one type of seizure could result in social isolation for decades and decades. And the second case I've taken from one of the book. This is The Secret World of Sleep by Dr. Gail Sinzer. He is the neurologist of the guys and the St. Thomas Hospital, London. He has opened up his own sleep lab, and he has presented one chapter in this book on epilepsy. And this 55-year-old female will be having feeling of choking and strangled on falling asleep. So she could not sleep. But whenever she used to go to sleep, she will have the feeling of choking and strangling, and she will wake up suddenly, and that will result in the daytime sleepy and affecting her behavior, affecting her the service, the job. She has been to different psychiatrists, and ultimately, and she is unfortunately having these problems ever since her childhood. So this thing can be so went undiagnosed, but when she went to Dr. Sinzer, they diagnosed and confirmed with extensive investigation to have epilepsy, temporal lobar epilepsy, and insular epilepsy. So recently, I'm working in the discharge ward, and one of the 70 years old lady with diabetes was admitted to the ward, not a discharge, but another ward for with hemichorea, abnormal movements of the one side of the body. And she was diagnosed with hemichorea because of uncontrolled diabetes. But in between, she has been having unresponsive episodes. So this was attributed to hemichorea. So one day, when she was waiting for her discharge arrangement, and services were, uh, social worker were arranging her discharge, the ward manager came to me that she was concerned that the patient is deteriorating rapidly. She is not eating and drinking since yesterday, and she's not taking her medication. But when she met her, she squeezed her finger, but she resisted opening her eye. So we wanted that this patient she is not fit for discharge and probably has some other problem which we should look at. So after a couple of minutes, we went for to review the patient. And when I went to the patient, it hardly had taken 10 minutes because I was completing the notes for my previous patient. And the patient was fully alert. She was smiling and communicating. So I called the ward manager. I asked her, "Did you see her in the same condition?" "Oh, no, no, she was absolutely in different condition. She's totally fine at the moment." The immediate diagnosis came into my mind was subclinical, non-convulsive seizure. So we discussed with her family, with her daughter, because she has been suffering from this problem for a long time. And so we discuss about the EEG, because the previous investigation about the CT and MRI were all normal in the neurology ward. Uh, we talked about the EEG, that about if you are able to do the EEG during the seizure, probably might capture the seizure. But if the seizure is over, in between the seizure, the negative EEG doesn't exclude the seizure or epilepsy. So we started with the treatment. So her hemichorea improved. She never had any unawareness episode, and she was discharged home, eating and drinking, but she could not walk, but she had improved considerably from her abnormal movements. So another 16 years old boy, the teen started having abnormal jerky movements of the arm and the leg. The problem was that he would just drop the thing from a hand or start kicking with the foot. And the family telling him, "Be careful. Why are you behaving like that? Why can't you hold on the thing? Why can't look at the thing? Why are you kicking everything around?" And just everybody was attributing all these things to the teenage behavior. But a couple of days later, he fell in the bathroom, and when Zob, "Oh, this is having this jerky movements of all the arms and the legs. Oh my God, this is seizure. And this is probably the myoclonic seizure she was having." So we started the treatment with the consultation of the neurologist, and he has been symptom-free for more than 1.5 years. So no dropping, no jerky movements, absolutely fine. So one more thing I want to talk about is non-convulsive epilepsy. This is or the status epilepsy. This is usually the patient seizure are not very obvious, but they're subclinical. The patient is not responding, has abnormal movement, the clenching movement, clenching the face, closing the eyes, and clenching the fist. So this thing can, you know, uh, can persist for a few minutes, but can persist longer. So if we request for the EEG and it's done during the seizure, can find epileptic discharge on the EEG. So that means that different types of epilepsy so there could be the focal epilepsy, temporal lobe epilepsy, generalized epilepsy. One type of the generalized epilepsy is um, myoclonic epilepsy that could results with the focal jerky movements and resulted with the complete tonic-clonic seizure. But another type I would like to discuss is the temporal lobe epilepsy, because this can present in a very different way than various ways, and quite difficult diagnosed. we attribute these symptoms to the habit or to some psychological issues. So the aura is the symptoms the patient get before the seizure, and a strong smell, certain strong smell, or a disruption of speech. Deja vu is have the familiar feeling when in the strange spaces, and Jamaisu is that feeling strange in the familiar places. The sudden sense of fear, panic, anxiety, anger, sadness, or joy. So another significant presentation is that rising sick feeling in your stomach. There's something coming up from uh, the stomach, and just feeling that get in your gut riding a roller coaster. So, and the belching, excessive belching could be the one of the presentation of the temporal lobe. Altered sense of hearing, sight, smell, taste, or touch. So this temporal lobe epilepsy could present in very different ways, in varied ways. So if you keep this thing in your mind, and if you think of temporal lobe epilepsy when you don't have any other diagnosis, and that probably will help in the diagnosis. And this could spread to the jerking or result of confusion, the loss of awareness, but not loss of consciousness. The stereotype that every time the patient gets the similar type of features, and so worsening association with the periods in women, especially estrogen, worsening and progesterone, are some sort of protective role. So that was the presentation about the temporal lobe. Another type of epilepsy I just described was the juvenile myoclonic epilepsy. This is the most common genetic generalized epilepsy in puberty. Myoclonic jars, uncontrollable sudden jerking, mainly of the upper limbs, but may also include a generalized tonic-clonic or absent seizure. And ECG shows typical heart for 6 hours spike waves or polyspikes, generalized epileptiform discharges. So sometimes can have the quite weird and wonderful manifestation, right? Like one of the young men would suddenly feel upside down in the world with vision turned through 180 degrees and diagnosed with the parietal lobe uh, epilepsy. So 60 years old man with temporal lobe epilepsy, feeling of religious ecstasy, being supernatural, and if the occipital lobe is involved, you can get the visual hallucinations. So because of the varied presentation of different types of epilepsy, especially the focal epilepsy, there has been delay in the diagnosis in some of the cases. And then there was a project that Dr. Jacqueline French has mentioned in her lecture was about Human Epilepsy Project 2016, in which 270 patients are enrolled, and the comprehensive history was taken, and the structure interview was carried out. And the result was that different type of epilepsy can have the delayed diagnosis from 119 hours to 15,798 hours. So, I mean, sorry, from 119 days to 15,798 days. That means from 6 months to almost 9 years. So there have been delay in the diagnosis from few months to many years. And the cause of delay was either the patient were unaware, they didn't know that this is anything which I need to talk to the doctor, or when they go to the doctor may be unaware, or the elective delay, oh, okay, it's no problem, just minor thing. I don't have to consult any doctor. So just see how bad or how good we are aware of these problems. In complex focal seizure, the focal seizure associated with the loss of consciousness, there has been delay in more than 78%. And the patient was unaware in 35%. And doctor was unaware in 20% of these patients who presented to the doctor, but doctor was not able to diagnose. Then the patient and the doctor both were unaware in 11% in complex focal seizures. In simple focal seizure, very again, delays more than 89%, and the patient didn't consult the doctor because they were unaware of the thing for more than 54%, and doctor couldn't diagnose because not aware of this seizure in 12% of the patient. So real life issues and delays and and the diagnosis of epilepsy. One, for getting ambulance after seizure, we call the ambulance, and either ambulance will not come or come late. When you take take the patient to the doctor, seizure is already over, and wait for the doctor and A&E. And after a few hours, you are seen by the doctor and sent home because you are not having any problem. Again, if I've seen with the doctor and want a neurologist advice, that guideline state that patient should be referred to the neurologist after first seizure, but getting appointment from the neurologist because they want to see you after MRI and EEG, and how much time is spent to getting the appointment for MRI or EEG, that depends upon the long waiting list. So it may be months. And then ultimately the diagnosis and all these things will lead to delay in the starting the treatment. And again, the follow-up. I have seen a patient who has been who was last seen by any doctor or the neurologist for epilepsy was 50 years. So how can we improve this situation? So think of, as a doctor, we should think of seizure with any diagnosis of hypoactive delirium. We are admitting so many patients with delirium and hypoactive delirium, and we are satisfied with the diagnosis. But the hypoactive delirium is not a diagnosis. We think what is causing this delirium? Is this the infection, sepsis? Is it Parkinson, or is Parkinson, atypical Parkinson, the Lewy body, or if nothing else, could it be a seizure? So think of seizure with anybody presenting with hyperactive delirium. Unaware or unresponsive episode, that this again another common presentation, especially in the elderly, and the patient has been unaware, just waiting and nothing else. There's a chronic problem, becomes unaware, so no diagnosis, think of seizure. Unwitnessed fall, especially with the loss of consciousness, received the patient, so fell from the top of the stairs down, head down, and brought to the hospital. And she was absolutely fine, was waiting for STAC for going home. So when we saw her and we took the history, so she just felt good at the rest of. So at that time, probably she was not aware how did she fall from the stair down. So when we investigated, so probably that was the epilepsy which had led to her fall. Unexplained neurological signs. Sometimes, you can localize the clinical neurological examination, but if you think that this clinical examination doesn't fit to any diagnosis, so think of epilepsy. In epilepsy, in most of the cases, the clinical examination will be normal when you see them. So if you find something abnormal and you can't fit into that particular diagnosis, think of epilepsy. Funny terms, this is the term used by most of the patients when you can't explain the thing. So when you use this word, please think of the epilepsy. So what I would ask the patient to give the details, and if the family, ask family to note the details. So what was the detail of the seizure? And that can help in the diagnosis of type of seizure. What was he or she doing on the onset of the seizure? Had the patient fallen? Level of consciousness at the beginning, and how long the patient remained unconscious? Eyes was rolled up, eyes closed, open, arm and leg movement, jerky movement, or just jerky movements and stiffness. So they really need to be told that need to observe all these features. Was there any tongue bite? Was there any urine or fecal incontinence? So these are the things which could not be ignored in any patient presented with any psychiatric issues or whatever you can label them. But they usually the fecal and urine incontinence doesn't happen in the conscious patient unless some neurological problem is there. But the any seizure accompanied by the tongue white, urine, and fecal incontinence, think of turning on generalized epilepsy. Duration of the seizure in the minutes, and if it persists for more than 5 minutes, immediately be taken to the hospital. Post-ictal condition, confusion. So that these are the features which we need to train the patient and the family, not the patient, the family, because they will be able to observe and record and note all these things. And if at all, because everybody has a mobile now, they can make a video and that of the video of the entire episode, and that will be helpful in diagnosis. This is the form used by and recommended by the International League on Epilepsy. So this cover form, the diagnostic interview conducted outside video EEG recording. So when asked the thing and is asked the comprehensive interview for the patient and document all these things. So will help in making a diagnosis. What is the very first thing that happens to you during this seizure type? Or is there a sense of smell, or is we seeing some shadows or some lights, whatever, just get the description, and that will help in making the diagnosis. Describe what happened next, and then in order the rest of the events that occurred with this seizure type. So all those things I mentioned in my previous slide. So these need to be um, explored in a sequential manner. How long does the seizure last? The seconds, 1 to 5 minutes, or more than 5 minutes? And do you have any other feelings such as fear, deja vu, or anxiety, which come out of context or symptom lasting seconds to minutes that appear with no apparent cause? Another very important question we need to ask our patient to reach the diagnosis. So that's all for this discussion, and these are my resources. I use these, the Medscape, the Dynamic Plus, Up to Date, the Secret World of Sleep, Google, YouTube lectures. So I hope this will be useful for you. Thank you very much, and see you next time.